to start off by saying that in our program of research, we had multiple studies. So I'll be talking about one of the 5 or 6, I think, studies that we had in the program of research. And this was kind of a unique methodology. It's called Q methodology. And it's a way to actually explore how people feel about a particular issue. And so it uses a different technology in terms of statistical analysis, which is different than what you just did. So I just want you to know that what I'm going to be presenting is not exactly the way what you did in the survey just a minute ago. But what the idea was to prompt you to think about your own values and opinions and how you think about primary care and public health collaboration. So what I'm going to do is talk about Q methodology for only a second, because that's not the point of today's session. Q methodology, though, just so that you understand how, when you see the results, you want to know how we got there. So basically, it's useful for exploring how people's perceptions, and also looks very much at interprofessional relationships, can ask about relationships, how people feel about them, which is good for this kind of work, right? To find out how do we understand each other and how do we work with each other. It also helps us identify where are there commonly agreed upon ideas and thoughts about a particular issue. And it also gives us distinguishing viewpoints. So we find that there are people that sit in one camp or another camp or a third camp, and that those are distinguishing viewpoints that distinguish them from other viewpoints. So that's what we wanted to do. We wanted to find out, and we wondered if primary care people and public health people felt the same or differently about this issue of collaboration. So the number of people or the percentage of participants that fall into a particular viewpoint is irrelevant. We really don't care about that. What we want to know is how many viewpoints are there and what are they about. So we actually try to identify those viewpoints, and we call them factors because it's done using factor analysis as a methodology. And it's a by-person factor analysis, which is a little bit different. So it basically runs the analysis to put people into groups. So you've got a group of people who fell into this factor, this factor, this factor. And the research team is the team that then has to identify how you name those factors. So what you're going to see is our struggles with naming factors and what we came up with. And there's a paper that we've published on it. I can give you the reference. There's a handout up at the front. That actually can just be a handout, I think. Okay. That people, if they're really interested, you can grab it. So what we found in our results was that there were 3 factors, or 3 major viewpoints. The first one is called system-driven collaborators, and I'll get into a little bit of the detail of this, but you had a couple questions about this. How much does the system influence what happens or doesn't happen? We had people who had very strong feelings that things are system really driven. The second group are cautious collaborators. So they're the ones who are kind of more at that organizational level thinking, yeah, I think we can, but there are roadblocks, there are things we need to do. They're a slightly different group of people having a different set of views. And then finally we have competent isolationists. These are the kinds of people that they basically think, I do my thing, you do your thing, and we'll work together, but not really together. But we know each other's roles, we know what we have to do. So as we dig into this, this is the question, the survey that you said, and people will say, well, you didn't have a dichotomous question, you had all these explanations and all that, what's that all about? Well, that's what I mean. Please don't use those statements as examples of how you would construct a survey, because it may not be quite clear as a yes/no, because it means it tried to help explain a point. That was the whole idea. And what happens is, in this study, they had 44 statements. We printed them on cards. Then they had to put those cards on this grid. So you can see these, all of the statements that fell into this middle section. People felt kind of neutral. They didn't really feel super strong one way or the other. And then when you do the by-factor analysis, you find out what are those viewpoints. Create these huge tables, come up with your factor name, and have your results. So I'm going to jump right past the methodology and get to the results, because that's what you want to know. And I'd like you to examine yourself and think, which viewpoint might I fall into? And those of you who have to work with you, what are they going to be challenged with? Or how can they use you and leverage you based on the viewpoints that you might hold? So, system-driven collaborators. These are the statements that they put way over on that. We strongly agree with these. I put believe that should say agree. Strongly agree that there needs to be a clear mandate from the top to enable public health, primary care, and the rest of the health system to work effectively together. And if you remember what you guys came up with on that particular question, you almost all agreed on that. So would you think that you're actually a system-driven collaborator? Maybe not, because we'd have to run you with all of the statements together, figure out where did you put that in that big matrix. Was it really the one way off on the left, or was it maybe more in the middle, but it just ended up, you know, it's relative to all the other statements where you put this particular statement. Does that make sense? Do you know what I mean? So the Q methodology does something different. These people also believe, and that different branches in the ministry would really have to believe in collaboration, support it, and write policies to have organizations work together. And they also think that there's leadership needed at the ministry, that they need models like community health centers where you've already got that kind of mentality with salaried physicians and a range of healthcare professionals where it's already kind of interprofessional. So you can see how these people really are driven by what's going on at the system level. They strongly disagree that differing mandates are a barrier to collaboration, and this has to do with, you know, population-based approaches versus individual approaches. They also they disagree that unions or funding differences between primary care and public health are a particular challenge. And they're quite neutral about all the other statements that are kind of written at that, or you know, what might happen at an organizational level or at an interactional level. That's why we named them system-driven collaborators. Then the next group, the cautious collaborators. So these people, let's see, where did they fall? I'm just looking for you guys, where you fell on this. So with regard to the first one, they need to have better consciousness raising about what collaborations are good ones, and about reflecting the ones that they currently have, so having a better understanding of what's out there. And they're the ones who also strongly agree that there are turf protection issues. You know, if you start to work too much with primary care, the public health people are going to get sucked in and have to do primary care work when they're supposed to be doing population level work, and vice versa. So there's that turf protection, which is, you guys actually had a real mix. You were arranged there in terms of your responses, everywhere from 31% to green, 22% were neutral. So, you know, maybe you're not cautious collaborators. These people strongly agreed on this. So far you're system-driven collaborators, but you need to reflect on all of the statements. Everyone feels that they're in capacity. There's no room for anything more. And this is a common issue, like where do I fit this into my busy primary care practice? I don't have time to go to meetings. I don't get paid to go to meetings. So that's one of the issues there. They also agreed that partners need to be consistently engaged in dialogue to resolve issues. And they also identified strategies for successful collaboration at that local level. So these people are thinking more at that organizational level, saying we need consistent dialogue, we need to start small, we need to have a memorandum of understanding. They didn't agree with the fact that they needed a clear mandate at the top. So this distinguishes them from those system-driven collaborators. They felt that they didn't think that they needed electronic communication mechanisms. And what did you guys say about that? I need to turn my page here. You disagreed with, yeah, 50% agreed. So these folks generally strongly disagreed with this need for communication. There's a lack of communication between government agencies since integration of high-tech communications are still at infancy. This, again, they strongly disagreed. They didn't care that much about what was going on there at the system level. Competent isolationists, this is a really interesting group. We only had 3 people, and we, like I said, we don't care about the numbers. I should say that the previous group with the turf issues, they were the Ontario. They were all from Ontario. That was the only differentiating factor, because we had people from across Canada in the room, but all of the ones that fell into that factor were Ontario people. So they strongly agree that it's necessary for primary care public health sectors to spend time to make sure that both parties clearly understand the differences between their roles. So this is about, you better know what you're doing, we are gonna know what we're doing. And we agree that, the problem is that we're not sharing courses, so hopefully we're overcoming this with you guys all being in a room together, which is terrific. I think that this is addressing one of the big barriers of collaboration, what you're doing right here today. And it's important, this was another agreement, that it's important for people to use the skill sets that they have rather than learn new ones, and to use skill sets other than those in collaborations. The reason why we put this in competent isolationists is because all of our other research said to be successful in a collaboration, you need to be able to be adaptable and flexible in your role. You shouldn't be rigid in your role. You should be able to cover. H1N1 comes, you guys in primary care, you might want to shift a little bit about what happens, because we need your help for H1N1, if you know what I mean. So that's why we identify these folks as competent isolationists. Different mandates are barriers to collaboration, and collaboration won't work if people haven't got stable and sustainable funding. So these are the kinds of things that they're agreeing with. What they disagree with is that they disagree that there's evidence on the benefits of collaboration. That was really important to them. They wanted to see, give me the evidence, right? Where the other people didn't find, they commented on it, but it didn't get on that extreme. They disagree that there is value in having any of these memorandums or people that writing policies or any of this other stuff. It was more about knowing who you are. Now this is interesting. They disagree that being physically co-located would lead to a better understanding. So these folks said stay in your own corners. So I think this would be probably the biggest challenge. If you've got some competent isolationists here, I bet you we're not going to be graduating very many of them. But I know there are some of these out there right now. And so this would be the challenging group that if you're going to have to try to get into some kind of project together or get a collaboration going, this would be the challenge. This group did not seem convinced about the value of collaboration, and they identified many barriers as well as differences between them. So that was kind of the way they fell out. How am I doing on time? I'm almost there. Okay, and with regard to the competent isolationists, I skipped over the one about physicians and nurses and social workers and sharing the courses, that issue, and you folks were mixed on that. You were all over the map on that. So that's good, because you didn't come up as being all agreeing, so I'm hoping that means there's not too many competent isolationists in the room. Okay. These are probably not particularly legible. I do have a handout if anybody's really keen. But one of the things I just wanted to highlight, I'm only going to read a couple of the points on this screen, is we also looked at where did people have consensus on an issue. So I'm going to give you the things they really disagreed with heavily and the things they really heavily agreed with. So they totally disagreed with the top item, which says, I think different work processes are a barrier to collaboration. For example, staff who work in clinical services work at very stressful sort of primary care, and colleagues who work in other areas of public health aren't in the same mindset, stress level, or pace level. So they strongly disagree. They didn't see that their cultures, because they are quite different, the pace and the stress levels in the day-to-day kind of feeling is, they don't see that as an issue. And the other thing they completely disagreed with was a lack of vision and collaboration is a barrier. For example, people are not being clear on what the end result is going to be. The things that they really I apologize, they agreed on that one. Of course, that they would have to agree on that one. So a lack of vision is a barrier, so they would want to have the vision. The next one is, I think politicians have research evidence to say that collaboration will save money. They completely disagreed with that. And I kind of want to end on that note, because you're all students and you're in an environment where research is research intensive. I think this is one of the main messages we got. Everyone disagreed that there's evidence to show that it works. So it's a challenge that I would put out to you to say, we need to really look for that evidence. So whatever you might do in your future, if you start some kind of a project, and this is kind of a hint of what you might do in the next activity, make sure that you've got some kind of an evaluation mechanism built in so that you can see if it's working or not. Because if you don't, this will be a problem. You won't convince anyone of it. And secondly, when you do find out what your results are, make sure you share them. We had some case studies where they did evaluation and they forgot to share them with the people people in the collaboration. And so they had no idea what the results were, where the problems were. So it sounds like a simple thing, duh. But it's surprising. Researchers get in their little nests, they do their research, and then it never gets out there for the people who are in the real world to figure out what to do with it and how to do some quality improvement. So this is the paper. I welcome you to have a look, and I'm going to open